This episode of the Science of Skin podcast is sponsored by Galderma.
Hello and welcome to the Science of Skin podcast. My name is Dr. Ted Lain. I'm a board-certified dermatologist and your host for today. I am joined by a very esteemed colleague, Dr. Andrew Alexis. Dr. Alexis is a professor of clinical dermatology at the Weill Cornell Medicine. He's also past president of the Skin of Color Society. Today, we are going to chat about Trifarotene cream. The brand name is Acleaf. It is a novel or new retinoid or type of retin-A cream that has been around, Andrew, for, how long now? I can't even remember when it was first launched.
You know, it's a great question. I lose track of time, but it's been a few years now.
It's been a few years now, yeah. And really, the wonderful thing about Acleaf is that there's been continued development and investigation about this new molecule. So we really understand how it works in the skin and some of the kind of interesting attributes of Trifarotene compared to its peers. Would you agree with that?
I would. And, we like to refer to Trifarotene as the fourth generation topical retinoid. And so it's wonderful to see an advance in this category of agents that we depend on so heavily when managing acne patients. And so when we think of the original retinoid of tretinoin, and then the development of adapalene and tazarotene, here we have our fourth generation retinoid molecule, Trifarotene.
It sure is an interesting molecule. Remember that tretinoin was is all trans retinoic acid, right? So it is a molecule that binds to all the retinoic acid receptor subtypes. So there are 3 receptor subtypes in all of our cells that tretinoin would bind to, but Acleaf or Trifarotene is different. Andrew, tell us how it's a little bit different.
Yeah, indeed. So Acleaf binds to preferentially to the RAR gamma receptor. So it's an RAR gamma agonist, and it turns out that RAR gamma is the predominant receptor subtype in the skin. So this is highly selective for RAR gamma.
We know that retinoids, pretty much all of them now, we know that they do amazing things for the skin. We use them a ton in acne because they have such beneficial effects on helping the skin cells turn over more quickly, and by accelerating the cell cycle, we're able to stop the cells from getting caught in the hair follicles, leading to what we call microcomedones or microscopic blackheads, which can then develop into the acne blemish of the pimple or the pustule that we commonly see with inflammatory acne. But then Trifarotene, again, through advanced investigation, does a lot more than that. And there's some pretty interesting genetic data, Dr. Alexis, that I think we should just kind of do a quick overview of.
Yeah, so it's interesting. This molecule, the more and more we learn about it, it becomes more fascinating. There was a recent gene expression study that you mentioned, Ted, that showed that there's activation of retinoid modulated processes, including epidermal differentiation, proliferation, stress response, proteolysis, cell adhesion, so a number of different effects. And some of these identified differences in gene expression might help to explain some of the clinical outcomes that we've observed with Trifarotene, including improvements in scarring and post-inflammatory hyperpigmentation. So one of the unique attributes or distinct attributes of Trifarotene is, in addition to the traditional comedolalytic effects of retinoids, it does have some potent and depigmenting, if you will, or reduction of excess pigmentation effects, as well as some effect on scarring, reducing atrophic scars. And I know we'll be talking about some clinical studies that support that too.
Yeah, you mentioned the scarring and some of the genetic data that's been been developed. I mean, they showed what I think 67 unique genes were affected by trifarotene, and these genes were related to the migration of cells, an inflammatory response, and extracellular matrix remodeling. But then, really interesting, the way the trifarotene affected macrophages. You know, there's two types of macrophages. Just broadly, there's the M1 and M2 macrophages. The M1 tend to be pro-inflammatory, M2 anti-inflammatory. But there's an actual subtype of the M2 macrophages. I feel so smart now talking about all this. It's called the SPP1 population. And that one, although it is part of the anti-inflammatory macrophage family, it is responsible for fibrosis. And we think that by targeting and downregulating these SPP1 type M2 macrophages, we're able to possibly decrease the scarring. And so maybe that's the pull through from what we see in some of the studies that we're about to talk about. Kind of, we're showing benchtop in vitro data that can actually be associated with phenotypic clinical data, which we always love to see. And that's kind of the investigation I was talking about that Galderma has really done with this molecule. But Andrew, let's just do kind of a quick overview of the phase 3 registration program, where it was essentially trifarotene versus vehicle, wasn't it?
Indeed, for the phase 3 trials, trifarotene versus vehicle. And yeah, I just want to reiterate the exciting gene expression data that you mentioned. And as you said, 67 genes that primarily involved in cellular migration, inflammation, and extracellular matrix reorganization. And those specific macrophages that you mentioned, SPP1 positive macrophages, are, as you pointed out, a subset of more proliferative macrophages that are found in fibrotic tissue. And so there's that link between what we have come to observe clinically with respect to effects on scarring. But back to the phase 3 data, compared to vehicle, trifarotene compared to vehicle demonstrated significant efficacy with respect to inflammatory lesions, non-inflammatory lesions, investigator global assessment of acne severity. But something that makes it quite unique in the retinoid class is that not only was it studied for acne involving the face, but also truncal involvement. So efficacy was demonstrated for both truncal acne and facial acne, which is particularly exciting.
Yeah, I really love the fact that they investigated on both, and essentially the same efficacy that we saw in the face, we saw on the trunk, which was surprising to me because I often consider the acne on the trunk as a little bit more difficult to treat. The trunk doesn't absorb topicals as well. It's a little bit more difficult to penetrate. The hair follicles are more spread out, which is where the acne blemishes arise. And so, we may need more medication in order to achieve the benefit just because the target is spread. But indeed, the results were exactly the same in terms of reduction of inflammatory and non-inflammatory lesions, which was surprising, but great because it allows us to use monotherapy for these patients.
Exactly.
Yeah. I think before Acleve, sorry to interrupt, before trifarotene, we were kind of using one retinoid for the face and then maybe some other products for the body. I don't know if this changed your clinical regimen at all.
Yeah, absolutely. To your point, Ted, before trifarotene, we didn't have such robust data for frankly, any therapy for truncal acne, to my knowledge. So the ability to use a retinoid, no less, for truncal acne and get this kind of efficacy has definitely changed my practice.
And then they didn't stop there, right? As I mentioned, we've learned so much more about how trifarotene can affect the entire acne journey, because I'm not sure that as dermatologists, we should consider our job done once the acne lesions have stopped arising or have been eradicated. I think there's more for us to do. I'd love to get your view on that.
Yeah. And I think what you're alluding to, Ted, is that, in addition to the papules, the pustules, the comedones, the actual lesions of acne that our patients come to us presenting with clinically, there's a whole other dimension to it, right? There are the sequelae of post-inflammatory hyperpigmentation, which can have as much of an impact on patients and sometimes even more of an impact on patients than the primary inflammatory or non-inflammatory lesions. Um, uh, Acne scarring, and then the psychosocial impact of having acne. And so we have all of these other dimensions beyond just narrowly focusing on lesion counts.
This episode of the Science of Skin podcast is sponsored by Galderma.
You mentioned the psychosocial aspect of acne. It's something I think about pretty much every time I see a teenager with acne, because we know from earlier data, again, data that is largely generated by Galderma, that when a teenager develops acne and the effect it has on their self-esteem, it's not like once you clear the acne, the self-esteem will immediately rebound. Unfortunately, we know from this data that the effect on confidence and self-esteem actually persists throughout adulthood as well. So that I always think about that, because when I have a teenager with significant acne, I think about how it's affecting them psychosocially and now and in the future, and how, boy, that puts a huge onus on us to get them better quickly, because the last thing we want is for them to be dealing with the psychological aspect of acne 10 to 20 years later.
Yeah, well said. And with that in mind, I think it's helpful for us as clinicians when we take care of our acne patients, particularly in the initial consultation, but really throughout the acne journey, to take one extra moment and ask our patients, assess how the acne might be affecting them in their social lives, professional lives, their overall self-esteem. And we can glean a lot of that, even if it's not said verbally. There are also many nonverbal cues, aren't there? We can see when we walk into the room.
Yeah, it's tough to be a teenager in any way. And then you add significant acne, and it just makes that journey even more difficult. I was lucky as a teenager. I just didn't experience a lot of acne, but I remember my friends that did, and what a struggle.
Yeah, not to overshare and get too personal, but I'll just, in response to that context, I can say that I certainly suffered from acne throughout my teenage years and even through my early 20s, and was treated during medical school too. So,
yeah. Well, let's jump into kind of. I'd love to actually get your thoughts on how you best utilize trifarotene in your just daily practice, and where do you find it slotting in and it's being the most successful for you, because I think that kind of takeaway will be huge for our audience as well.
mm-hmm. Yeah. So, first of all, taking a step back, I view retinoids as really the foundation of our approach to treating acne. And so the ability to use an advanced retinoid, this fourth generation retinoid with RAR gamma selectivity, with facial and trunk data and some other data that we're going to talk about, it's really become one of my go-to retinoids when it's accessible for my patient. So I'll frequently use trifarotene, have my patients use trifarotene at night, and whether it's on the face or face and trunk, depending on their involvement. And then for the morning, even though the clinical trials demonstrated monotherapy, demonstrated efficacy with monotherapy, in the real world, of course, we will combine multiple agents to try to target multiple etiologic factors, pathogenic factors for acne, and increase the overall efficacy. So I might have the patient use a benzoyl peroxide clindamycin formulation in the morning, coupled with the retinoid at night. They might use a topical azelaic acid formulation if their sensitivity to benzoyl peroxide, or if there's a sort of urgency to work harder on the hyperpigmentation front, and having two agents working on hyperpigmentation at the same time, the retinoid and azelaic acid. These would be some examples. Or the clascoterone, another one of our newer agents, in this case targeting the the sebaceous gland and inhibiting an androgen receptor there. That's also potential combination of retinoid at night and clascoterone in the morning. So there are many different combinations that one can consider on a case-by-case basis, depending on the clinical severity, the predominant types of lesions. And this is not to exclude oral therapies. So there are scenarios where patients will have more severe acne and will combine topical regimen, including trifarotene, with an oral agent like doxycycline.
Wow, it sounds like it's really a foundational, like you said, it's variations on a theme, but that theme is trifarotene for a lot of your patients.
Indeed.
Yeah, I have to agree. I think retinoids play such an important role in acne, and the more and more we learn, as we're going to discuss now, the more important they are. And in addition to that, the beneficial aesthetic effects of trifarotene cannot be understated. I use it. I don't have acne, but I use trifarotene every night because I think it has amazing benefits just aesthetically to improve collagen production and decrease pore size. So I like it for the other benefits in addition to its acne fighting benefits. But let's go into those phase 4 studies. I mean, I think we've danced around them. It's probably time for us to actually talk about them. There was a phase 4 study called the START trial, which really looked at acne scarring. And I think, in preparation for this trial, and Galderma had performed a trial much like this with previous generations of products targeted acne. And they found that not all acne scars, usually we think of a scar as being something permanent, but indeed they showed that through some really interesting data that not all scars are permanent, are they?
Exactly. I think that, and as you pointed out, there were some previous Galderma sponsored studies with earlier generation product that first set the stage for having a better understanding of the role of topical retinoid therapy in atrophic acne scars. It's actually remarkable to look at that data and see that we can reduce the number of atrophic acne scar lesions with retinoid therapy. And specifically with Aclif, this phase 4 study with Aclif was a split face design where half the face is randomized to trifarotene cream treatment once daily, and the other side with vehicle. And the number of atrophic scars were assessed at various time points over the course of 24 weeks. And in order to qualify for the study, of course, in order to do a split face, these are patients who have symmetrical involvement of atrophic scars caused by acne. And patients had to have at least 10 atrophic acne scars to qualify. And so when looking at the efficacy for this, what was demonstrated was statistically significant reductions in not just the acne, but also in the atrophic acne scar count over the course of 24 weeks. So at week 24, there were significantly greater reductions from baseline in the trifarotene side versus the vehicle treated side.
Yeah, it's interesting. Even prior to this data, they showed that about a third of scars are actually transient. So not all scars are going to stick around forever. But then they also looked at which type of lesion leads to an acne scar. And it's the post-inflammatory lesions that predominantly cause acne scarring. So for example, those post-acne PIE, the post-inflammatory erythema, for example, that we look at those kind of red marks on the skin that are the remnants from the papular pustule. Those are the ones that tend to form. 8 out of 10 scars are derived from PIE. So that's what we were talking about earlier, right, Andrew? Like, is our job done when we get to the PIE? I think we probably are not done at that point because we know if, my goodness, 8 out of 10 scars are derived from PIE, we need to keep going with treatment in order to hopefully prevent that, right? And I think trifarotene fits right in there.
Absolutely. And I'm so glad you brought this up because it now brings to our attention the fact that we're probably using these terms as they're probably misnomers. We say post-inflammatory hyperpigmentation, post-inflammatory erythema, and I think increasingly we recognize that these are actually misnomers, and there really is subclinical inflammation in these areas. Of course, with PIE, you see the inflammation, as you can see the persistent erythema, but in the context of post-inflammatory hyperpigmentation, the eye might only pick up what appears to be increased pigmentation, but subclinically, there is histologic evidence of inflammation. An old study by Rabat-Halder years ago demonstrated that, and knowing the scar data, it makes sense that these very lesions would be the ones that would have a high risk of developing atrophic scars.
Yeah, and just to kind of quantify the scar reduction, if we look at that side of the face on average had about a 51% reduction from baseline in terms of the number of scars at week 24 versus 23% on the vehicle side. So we certainly see a very large difference between the active versus the vehicle side. And, what's interesting also is that this is some of the first data where we've seen week 24 data in terms of acne efficacy or trifarotene efficacy just in inflammatory acne and IGA success. And we, if we look at this data, week 12, we had about a 58% reduction in the total lesion count, going down to 70% reduction at week 24. So we don't seem to plateau with this drug either in terms of its efficacy. And that I love to, now that we have that week 24 data, I talk about that all the time with patients. I don't know if that has helped you with your discussions.
Yeah, absolutely.
It's great to have the data showing continued improvement over time, because we know with acne, it's not a sprint, right? It's a marathon. We're not curing, we're controlling. And that we can do with trifarotene, as shown with that data, and deal with some of the sequelae, such as the scarring. Now that is the START study. Andrew, the other study, it's called the LEAP study. And I think that one's the one that we probably should spend even more time on, because that one's associated or focused on the post-inflammatory or acne-induced hyperpigmentation. As you said, misnomered.
Yes. That terminology is very intentional.
Yeah.
Acne-induced hyperpigmentation, or AIH. And when working with this study, we thought carefully of the terminology, and that's not an accident. It's acne-induced hyperpigmentation instead of post-inflammatory hyperpigmentation. So glad you called that out.
Mm-hmm.
So the LEAP study that you mentioned, Ted, yes, it was a phase 4 study of trifarotene to assess its efficacy in acne-induced post-inflammatory hyperpigmentation. And we have data in terms of retinoids and hyperpigmentation. We have data dating back all the way to the early to mid 90s with tretinoin, demonstrating that tretinoin could improve acne-induced hyperpigmentation, but it did so with a pretty high rate of irritation in those days. And since then, we've seen some small studies with tazarotene, some observations of improvement with adapalene, but no formal, big, robust studies that are vehicle controlled for acne-induced hyperpigmentation until now with trifarotene. So this really builds on our overall body of data for using retinoids for hyperpigmentation. So this study was a 6-month study or 24-week study, and patients were randomized to either trifarotene cream plus a skincare regimen that included a gentle cleanser and a moisturizer containing sunscreen, versus the group that got vehicle as well as a moisturizer containing sunscreen and a gentle cleanser. And it turns out over the course of the 24 weeks, both groups did show reductions in hyperpigmentation, but there was a significantly greater reduction in at least the secondary endpoint called PAHPI score, PAHPI, which is post-acne hyperpigmentation index, which takes into account lesion number, size, and extent. And with that particular secondary endpoint, there was a significantly greater improvement at week 24. The primary endpoint actually was a more sort of general overall assessment of hyperpigmentation severity called ODS, which stands for overall disease severity. In that using that particular outcome measure at week 24 was actually a non-significant difference. But at earlier time points, there was significantly greater improvement in hyperpigmentation in the trifarotene group versus the vehicle. So I know that's a very long and somewhat complicated answer, but the bottom line is that there were the primary efficacy endpoint chosen in this study was a more of a general measure of hyperpigmentation called ODS, and at that 6-month time point of week 24, which was the primary endpoint, it was a non-significant difference. But using the secondary endpoint of PAHPI, a validated tool to measure acne-induced hyperpigmentation severity, there was significantly greater improvement in trifarotene. So your thoughts, Ted?
Yeah, I think it's such an interesting study. And, I think the ODS was a relatively new scale when this study was started. And so I think there was a lot of discussion, and I'm sure you were involved in that, Dr. Alexis, in regards to which is our primary endpoint. And it turned out that the ODS probably wasn't the right scale necessarily to use as primary, just because with good sun protection, we saw that the vehicle, those on the vehicle plus sun protection, I should say, caught up eventually. Although we saw
Exactly.
a much quicker reduction in the overall kind of gestalt improvement with trifarotene. In my view, looking at this data, I really would focus more on the secondary endpoint, the PAHPI score, because it does, as you mentioned, include the size of the pigmentation spots, the number, and the intensity, which I think patients actually focus on much more than the overall disease severity, because if they have even one spot that's still dark, it drives them crazy. And we see that as derms, we see that all the time. And so by showing you a reduction in those 3 metrics grouped over time, I mean, it's significant in terms of the improvement as compared to vehicle. As early as week 20, we get statistical significance spread more at week 24. And remember, this isn't just against a vehicle, it's against sunscreen as well. And we know that good use of sunscreen will reduce pigmentation. It's always difficult, in my view, to get statistical significance against a vehicle plus a sunscreen when you're going after pigmentation. And so this is some really good data to show kind of what we said before, which is what we saw with the gene expression. The in vitro data is pulling through now to in vivo human data with this acne-induced pigmentation. So, this, to me, Andrew, the START plus the LEAP data gives me the idea that it is incumbent upon us to treat these patients throughout their entire acne journey, as we've been mentioning.
Well said, Ted. And, the fact that the vehicle group that included a moisturizer with sunscreen demonstrated improvement. It also supports our treatment paradigm, where we emphasize the value of photoprotection when treating hyperpigmentation. And I think it's a case of selecting, in retrospect, maybe we could have thought twice about the ODS being the primary, at week 24 anyway, being the primary endpoint, as the ODS seemed to show a separation early on. At week 12, there was significantly greater improvement in the overall hyperpigmentation at week 12. But as you said, the vehicle caught up by week 24 because of the photoprotection.
Yeah, I mean, it's a good point. If it was a 12-week trial, we wouldn't even be talking about PAHPI at all, because we have such great data with the ODS. But I think it's good. It's great data, and with the SCAR data as well. So again, this is my kind of, I'm on my soapbox here, but I really feel like the derm community needs to, usually we say, hey, look, you've got to keep using your creams because you're controlling the acne. But I think it may be, it might resonate more, especially with our younger patients, to say, hey, we need to keep using the cream because all the results of the acne can be improved with this cream as well. So we can help you with the brown spots. We can help you with the scars if you keep using the cream. To me, since I've had this data and I've changed my narrative with the patients, I feel like I've gotten better compliance through long-term use because they feel like they're still treating something versus trying to prevent something. And I think prevention in a teenager just doesn't resonate.
Right. And, honestly, just as an anecdote, I think, and I'd love to hear your perspective as well. I think that once patients are on therapy, even when they're clear or almost clear from an acne standpoint, I think the majority of my patients actually see the overall benefits to their skin and are motivated to continue using it. They're not in a hurry to stop when educated about how retinoids work and the potential long-term benefits of using them. So at the end of the day, they do see the overall improvements in their skin beyond just the active lesions of acne. So they tend to be pretty satisfied to continue long after 12 weeks or 24 weeks.
Well, I agree, and I think that's a good way to end. So, Dr. Alexis, thank you so much for your time and walking us through the plethora of data supporting the use of trifarotene for our acne patient. My name is Dr. Ted Lain. Thank you again for listening. Listen, if you liked the podcast, please give us a 5-star review. And we found that the growth of the podcast really comes from word of mouth. So if you could tell your peers, your associates about the Science of Skin podcast, we surely would appreciate that. We appreciate you listening, being a skin sider with us and learning more and more about all there is to know about the dermatology community and the industry as well. So thank you for listening.
This episode of the Science of Skin podcast was sponsored by Galderma.